Welcome everybody to the February 2025 National Urban League Health Equity Webinar Series. Today we're talking about our hearts. As those of you who may or may not know, I'm Lydia Isaac. I'm the Vice President for Health Equity and Policy at the National Urban League. And so far for the past few years, a couple of years that we've been doing this webinar, we've made sure that we focused on heart health in February. We know that February not only is about Valentine's Day and your heart and those you love, but it's also about your actual heart. We have had a big campaign, the United States in general has a big campaign around heart health in February, and particularly for Black women and heart health, because we know that cardiovascular disease, and we'll talk a little bit, and I'm so excited about to have our panelists here, and I'll introduce her in a moment. We talk a lot about heart disease as the #1 killer of anybody in the United States, and particularly of women, even though people seem to fear breast cancer more, and it's an important condition, but it's not the #1 cause of mortality in the United States. It's actually heart disease. But heart disease encompasses many, many conditions and many, many things. And so in our past heart health webinars, we've really focused on kind of the precursors to heart disease. What can you do to prevent heart disease? Why do people get heart disease? But what we want to talk about here, and we're so lucky to have a medical professional here with us today, we want to talk about what are the different types of heart disease. Heart disease, cardiovascular disease in general, is an umbrella word for many different conditions with many different causes and outcomes to those conditions. And so we want to spend some time here kind of demystifying this CVD risk, cardiovascular disease risk, and having cardiovascular disease. So I am so excited to make the connection that we have here. And we're so excited to have a medical professional. So I practiced this before, but I'm going to be nervous and I'm going to get this wrong, but I'm going to actually get this right. So we have Dr. Isiadinso, did I get it right?
Perfect.
Isiadinso here. And I think it's important for us to know that our connection to Dr. Isiadinso is from the Black Cardiologist, the Association of Black Cardiologists, which is an important association who are really thinking about heart disease and cardiovascular disease within our communities. And so we're so excited, and I just want to thank the Association for Black Cardiologists for connecting us because it's important for us to make sure that we have resources in our communities that can help us to deal with the #1 killer of the United States. And I also want to thank Cytokinetics, which has sponsored this webinar, and in particular thinking about heart health and how important heart health is for our communities. So Dr. Isiadinso, I'm going to say it wrong every time, but I'm going to get it right. Can you just introduce yourself? Tell us where you practice. Tell us what you do. Tell us a little bit about the Association for Black Cardiologists and why they're such an important association, and then we'll get into the questions.
Yes, thank you for having me here. As you mentioned, my name is Dr. Isiadinso, and I am a preventative cardiologist, and I am honored to be the co-chair for the prevention committee with the Association of Black Cardiologists. The Association of Black Cardiologists is an organization that is not just for cardiologists, I will say, but for any of the practitioners who is interested in really preventing cardiovascular disease within our community. In addition to being comprised of cardiologists, internists, family practitioners, there are also key stakeholders that are aligned with the Association of Black Cardiologists and support the efforts of the organization to make a difference and to reduce the cardiovascular disease disparities in the underserved population. I am an associate professor of medicine at Emory University Hospital in Atlanta, rather. And in addition to my focus on preventative cardiovascular disease, my other interests are in the management of cardiovascular disease in women, as well as addressing cardiovascular disease risk factors and treatment of those who have clinical cardiovascular disease among individuals who have lupus and rheumatoid arthritis.
That's fantastic. And thank you for all the work that you're doing. Because that's really important. And I'm gonna, you asked me earlier about going on the list of questions. We have a set of questions that we want to make sure that we get to, but I do want to start with, can you talk to us about the difference between a preventive cardiologist and a cardiologist?
Yeah, yeah.
Why would you see a preventive cardiologist and why would you just see a cardiologist?
That's an excellent question. So there are different types of cardiologists. So a preventive cardiologist is one who focuses on prevention of the development of cardiovascular disease or in preventing a second event among those who've had some sort of atherosclerotic cardiovascular disease. So if you've had a heart attack, if you've had a stroke, and you want to look at your risk moving forward or ensure that all of your risk factors are being treated appropriately, then you see a preventive cardiologist. Someone may also be interested if they have no cardiovascular disease, but maybe they have a family history of cardiovascular disease, and they're interested in finding out what they should do to prevent developing any symptoms or a cardiac event. And then finally, you have the individual who really just is interested, who has no family history, who has no clinical cardiovascular disease, but really wants to take a more of a preventative approach to ensure that they have a healthy lifestyle for as long as they can. And they want to know, are there any tests that they need to undergo? What risk factors should they be concerned about? Does their pregnancy history relate to future cardiac risk? They really want sort of an informed discussion of all the strategies that they can employ to prevent cardiac disease moving forward. So we sort of tackle all three populations.
And so what does a cardiologist do?
Yeah, so a cardiologist is anybody that specializes in the management of patients who have heart disease, so cardiovascular disease. So within the scope of cardiology, there's a preventative cardiologist. There's also an electrophysiologist. Some of your audience members may have heard of, we call them the rhythm doctors. So if you have maybe atrial fibrillation, you have palpitations, you may see an electrophysiologist. There's also an interventional cardiologist. Now, these are the folks who do the procedures if you happen to have a blockage in your artery and you need a stent, then these are interventional cardiologists. So we're all cardiologists. We all just have different areas where we specialize.
That's fantastic. That was actually going to be my next question. So when I started, I talked about this idea of a big tent of cardiovascular disease. We use cardiovascular disease particularly to describe a lot of different conditions. Can you go through a little bit what would be under this big tent? And I'm going to name some just to start with, but I'm sure because you are the expert, you have more that I don't even think about. So we think about heart attacks, we think about strokes, we think about AFib, as you just said. We think about cardiac arrest, which is different from a heart attack, which we can talk about. I would like us to talk about what the difference is. So can we talk about each one of those and why it's important to understand what it is that you are being impacted by?
Yeah. So cardiovascular disease, just as you said, is a big umbrella of any sort of disease that affects the heart, the cardiac portion, or vascular. So even stroke or peripheral arterial disease, those are forms of cardiovascular disease. Hypertension is a form of cardiovascular disease, and long-term untreated hypertension actually can impact the heart or other organs, the brain. Untreated high blood pressure can cause a stroke. It can affect the kidneys. So that is a form of cardiovascular disease, hypertension. As you mentioned, atrial fibrillation is a form of cardiovascular disease where you have an abnormal rhythm that increases the likelihood that somebody would have a stroke if they're not on a blood thinner. To be honest with you, there's a vast number of conditions that fall under cardiovascular disease. But I think what I would want your audience to understand is A, when you have a history of heart disease, it's important to know what that specifically is. So if my patients come and they tell me that their dad had heart disease, I'll ask, did they have a heart attack? Did they have a stroke? I want to know a little bit more about that. So I know if this is something that you're increased likelihood of having yourself, this particular condition. And I also want to know at what age it occurred, because we know those who have had ischemic heart disease or a blockage in the artery slash heart attack in men before the age of 55 or women before the age of 65, that is a risk factor for cardiovascular disease for you. That's premature cardiovascular disease. And so it's important that we know that.
So I'm gonna ask you a question that's similar to that too. So I love that you said it's important that we know that. So when does a patient know that? And then What should we ask our family members, particularly our parents and our grandparents, if they're still around, about? Because, particularly in our community, oh, he has something wrong with his heart. He has a bad heart. That's all we say. It's a bad heart. They got, they got bad sugar. We use these kind of terms. Well, what should we be asking kind of more specifically? And if they don't know, what should we be asking helping them to ask their doctors more specifically, what it is that they have?
That's an excellent question. Let's just talk about the conversation you should be having with your doctor. So your clinicians, whether it's your doctor or if you see a nurse practitioner or a PA. Firstly, I always encourage my patients and even my own family members, when you go to your appointment with your clinician, take a book, take all the questions that you may have, because you don't want to leave that appointment still feeling that there are some answers that you didn't receive or that you wish you had asked this question that you thought of. Remember, this is a relationship. We're working together, the patient and the clinician. And so I can only assist when I know all the information and then I can educate you about your risk. But then you have the right as the patient to also understand what your risk is, what disease you have, what treatment you should have, and what are your options for treatment. This is not a one-way street in either direction. It really is a collaborative effort. I'm glad that you brought up the family history, because this is an area, as you mentioned, especially in the Black community, where we don't talk about this enough. I have many patients. In fact, I had one just last week who had familial hypercholesterolemia, which we'll talk about a little bit later. But there were 3 generations of family members who had high cholesterol, but no one ever talked about it. So when I saw this patient and I was making that diagnosis, she later talked to her mom and she said, "Yeah, I've had that since I was in my 20s." So it's important for us, A, to talk about all of our illnesses, right? You talked about breast cancer and how that is the biggest concern for women when it comes to the greatest risk for their health. But we know that cardiovascular disease is the leading cause of death in women. 1 in 3 women dies from some form of cardiovascular disease. We need to know about whether you have high blood pressure, if you had diabetes. Maybe I am going to get it. Even something as simple as menopause, to be quite honest with you, that's a little bit genetically predetermined. So if your mom went through menopause at 53, you may go through menopause at 53. So I don't want to restrict what we should talk about. I think, especially in our community, because we're not talking about it enough, we should always be talking about what is going on in our health, because A, your family may be able to assist you in caring for yourself and asking the right questions. And then if I am a descendant of yours, it's important that I know what I may be at risk of getting so that I can now take the steps to prevent the development of any of those illnesses. Maybe I need to be losing weight so I don't develop a diabetes. Maybe I need to see a preventive cardiologist or a cardiologist much earlier if mom had a heart attack when she was 50. But if I don't know that, I no longer have the opportunity to even take that first step in preventing any disease. So I almost think of it as if I don't want us to put our loved ones at any disadvantage where they can't take the first steps in really empowering themselves to live a very healthy life.
And taking that advantage, I want to go to our next question, which is about what are the traditional, risk factors for cardiovascular disease, and what are the things that are unique in particular to women? Because I
Yeah,
do think that is important, because we are finding that women present differently, particularly in terms of symptoms for cardiovascular disease.
you're absolutely right. So just starting with the traditional risk factors. The traditional risk factors, which, and by that I mean those risk factors that are the same for both men and women as far as being a risk factor for cardiovascular disease: hypertension, also known as high blood pressure, diabetes, high cholesterol, particularly when that bad cholesterol, the LDL, is high, or the HDL, the good cholesterol, is low. Smoking, whether you smoke yourself or you were exposed to secondhand tobacco use. That's a question that I ask my patients as well. We talked about the family history. That's a risk factor for cardiovascular disease. And then lastly is obesity or physical inactivity. I like to make sure I hone in on that physical inactivity, because I have a lot of patients who may not be overweight, obese, or obese, but the fact that you do not exercise, that actually is a risk factor for cardiovascular disease. In fact, the current sort of saying is that sitting is the new smoking. That's how much of an impact it has on one's health, the lack of exercise. As far as women, we know that there are some risk factors that are unique to women. So while all the ones I mentioned can occur in women and do increase one's risk for cardiovascular disease, women who are postmenopausal, we know that that is a risk factor for cardiovascular disease. Our estrogen levels are lower. We tend to develop what we call metabolic syndrome, where there's more fat deposits around the abdomen. We gain weight. Our cholesterol also changes during that menopausal period, where you have higher levels of those bad cholesterol and lower levels of the good cholesterol. Pregnancy is also a really important time for women, and it really does inform us about future cardiac risk. So for women, if you had what we call hypertensive disorders of pregnancy, maybe you developed hypertension and you've never had it, or you had preeclampsia or even the more severe form, eclampsia, that is associated with the future development of hypertension and the possible risk of future cardiovascular disease. Gestational diabetes is another one that is associated with the future development of type 2 diabetes, but it's also a risk factor for future development of cardiovascular disease. So it's really important that as women that we are discussing with our clinicians what our pregnancy was like. In the cardiology world, we like to think of pregnancy as similar to a stress test. And so how well a woman goes through her pregnancy actually informs us about her future cardiac risk. There's two more I wanted to mention, and that includes rheumatoid arthritis and lupus. You may be surprised to hear me say that because that's not really unique to women, but we know that more women than men actually have lupus and rheumatoid arthritis, and actually more specifically, more Black women than white women, for a number of reasons that are related to the inflammation that occurs with lupus and rheumatoid arthritis. Those two conditions are actually associated with future development of cardiovascular disease, and more importantly, is actually associated with higher risk of early plaque formation. So if you have lupus or rheumatoid arthritis, it's really important that you're talking to your clinician or seeing a cardiologist to understand what your risk is and if there's anything else that you need to be doing to reduce your risk of a cardiac event, given that you have those two conditions.
Wow, I've actually never heard that before, so that's really important. And you're right, lupus is very has high rates in our communities, and so understanding that link is important. I want to go to our questions about hypercholesterolemia because
Okay.
you made a really good point. We hear a lot about hypertension. We hear a lot about smoking. I don't know if we hear as much about high cholesterol and why that's so important toward cardiovascular disease. So can you explain to us what it is and why it's so important and how it can be an indicator, as you just said, looking at and then also, can you explain to folks difference between HDL and LDL? Because I confuse it every time I look at my my test. And so just to give us a refresher on what that is.
Yeah. So the LDL is the bad cholesterol that tends to be more associated with cardiovascular disease. So the plaque formation that we see in the arteries, that is actually plaque containing cholesterol, more particularly the LDL. And I always say the easiest way to remember it is the LDL is the bad cholesterol, so you want that to be low. It starts with an L. And the good cholesterol is the HDL, and you want that to be high. Typically, in women, we want that to be above 50. In men, we want that HDL to be above 40. Our body makes cholesterol. We need cholesterol for brain function, for our cell membrane. So it's not bad to have cholesterol. It's when we have really high cholesterol, that's where the problem is. Now, some of this cholesterol comes from our diet, right? Some of the foods that we eat, if we're eating foods that are highly processed or highly fatty foods, especially if they have trans fats or if they are fried foods. But our body makes cholesterol, right? And so we know that high cholesterol is associated with atherosclerosis, plaque formation that can cause blocked arteries that will result in heart attacks or strokes. But there's a specific type of high cholesterol called familial hypercholesterolemia. This condition is where there is a genetic form of high cholesterol, where your body either makes too much of it or doesn't have the right proteins to help you clear it out of your body. You're born like this. It's actually not uncommon. So there's one type where if you inherit just one gene from one parent, that's called heterozygous familial hypercholesterolemia. Sometimes we abbreviate it as FH. So in heterozygous FH, that occurs in about 1 in 250 individuals. Cholesterol levels, that bad cholesterol LDL, would be above 160 or 190. That's associated with early onset heart attacks and strokes as early as 40s, 50s. The other type, homozygous FH, where you inherit the gene from both parents, now these individuals are at even greater risk of very early onset of heart attacks and strokes, specifically as early as age 20. And their bad cholesterol, the LDL cholesterol, can be as high as 400. I've even seen higher. To treat cholesterol, regardless of what form you have, it will require, in addition to lifestyle changes, medication, especially when you have the genetic kind. You really need the assistance of medications to help get those numbers down. And the more severe form that you have, you require more than one medication. So this is why it's important to discuss this with family. I'll give you a very quick example. I had a 30-year-old patient who I saw probably about a year ago, and she had high cholesterol, which we diagnosed just routine testing. We did a cholesterol panel, and her level was high enough that I was concerned that this was familial hypercholesterolemia. And I asked her to get her children tested. She had a 6-year-old and an 8-year-old, and both of them had high cholesterol. And so now all three of them are on the same cholesterol medication. And that was really just us diagnosing her and her talking to the pediatrician for her children and finding out that they too had high cholesterol. So, I mean, they could have gone their entire life having such high levels untreated, which would put them at risk of early heart disease.
No, thank you for that. That's really important. I think sometimes we don't look at the whole picture. We've been talking a lot. I love that you keep on saying a heart attack means when you have plaques on your heart
Mm.
and and a blockage, and that's what causes a heart attack. So what is heart failure?
Great question. So, heart failure is a process where the heart cannot pump to meet the demands of the body. Essentially, the heart is unable to pump the blood out to get to the tissue so that if you're walking, you don't feel short of breath, or the reverse, where the heart pumps fine, but it's slow to relax. It's a little stiff and it causes the individual to hold on to fluid. So I know some of your audience members may have heard of congestive heart failure. So that's where the heart has difficulty pumping the blood out. And I always say, whatever doesn't go forward goes backwards. And so they end up with fluid buildup in the lungs, in the abdomen, or in the legs, and they're short of breath. So that's what heart failure is. It's just where the heart is unable to meet the demands of the body and it can't pump well. It just can't get the blood out to the tissues.
So heart failure doesn't normally lead to a heart attack. What does it lead to?
Yeah, so the heart failure doesn't have to equate to a heart attack. It can cause, if the heart pumping function is so low, it can increase one's risk of having arrhythmias, right? And that can cause sudden cardiac death. It can also result in a lot of debility because you're not able to walk up a flight of stairs without feeling short of breath. Some people may feel like when they're laying down at night, they're suffocating, they're just drowning in fluid. And so that's sort of some of the symptoms that heart failure will cause. Fatigue, where you're not able to participate in everyday activities. And really, there's some really good medications that are currently available in order to treat heart failure so people can live longer lives and be symptom free.
Fantastic. Thank you for that. And then cardiac arrest is what?
Yeah, that's where the heart stops, right? And so no matter of what pathway gets you there, whether you've had a heart attack and your heart stopped, whether you had an abnormal rhythm and the heart stopped, um, That is what cardiac arrest is. A lot of of your audience may be familiar with some football players, right, and who had cardiac arrest. I think it was about a year ago or so, while playing on the football field. And so it is something where the American College of Cardiology is being very intentional about educating the public on what can be done to increase awareness about cardiac arrest. Certain states, including ours, has pass some legislation so that they can increase the use or availability of AEDs, those automatic external defibrillators, within the school system, so that if somebody does arrest, that immediately you can provide life-saving therapies and resuscitate them.
I think that's really important after Damar Hamlin's cardiac arrest on the field. I think it was 2 years ago, who played for
Years.
the Buffalo Bills. You know, it did bring a lot of awareness, and he actually himself really started to get into advocacy around these issues. And one of the things that you know, and even in our offices, what we did is get an AED. It's to make
Wonderful.
sure every so it's something that's not an easy fix, but something that you can that everybody can do. Is they're not actually that expensive, is get an AED in your office so that if somebody does go into cardiac arrest, besides trying to do CPR, which, you know, it can help, but
Yes.
AED is quicker, and if you know how to use it right, has a better success, a better kind of success rate than
Yeah.
CPR. So I just wanted to mention that because we actually it actually made us think, you know, for us about that, and we're like, oh, you know, do we have AED in the office? Or
Yeah.
and we didn't, and so we
Well,
got
that's the whole point. I think that this is what is important about increasing awareness, education, and sharing information, is that that actually can lead to action, right? Now everybody in the office is aware that this is possible, that but if somebody does arrest, whoever, some of us are going to be CPR trained, and the rest of us who are not CPR trained or who are already CPR trained know how to use an AED. It actually resulted in action very quickly, just seeing that. So this is why I really am passionate about education awareness, because you empower individuals to make the changes within their communities, such as your office, or even for their own individual lives.
right. No, that's fantastic. And so we wanted to get on something also, another going on the theme of, you know, we don't talk much about cholesterol. I want you wanted to discuss, and I think it's important for us to discuss lipoproteins,
Oh,
and why is it associated with cardiovascular disease, how is it inherited, and you know, what can we do to get tested for it, and you know, any treatments that are available.
yeah. So you're referring to lipoprotein A, which is another genetic type of molecule that is associated with increased risk of cardiovascular disease, specifically strokes, heart attacks, and actually developing calcification on the valve that can progress to the point where the valve doesn't open and may require replacement. The lipoprotein A looks somewhat similar to that LDL cholesterol, but it actually is a little bit worse in its effect with causing atherosclerosis or plaque formation. It is an easy blood test that can be done. And the good thing is that it only needs to be done once in a person's lifetime. Because it is almost 70 to 90% genetically predetermined. Again, this is why it's important to have these discussions with our family, because if I get tested and I have high lipoprotein A, I now need to notify all my first degree relatives, all my relatives, so that they can also get tested for lipoprotein A. I like to say that this is the things that we should be discussing at baby showers, at christenings, at Thanksgiving, and family reunions. We need to be talking about our family history, about all these conditions. Currently, there are no FDA-approved medications specifically targeting lipoprotein A reduction. But what our focus is right now is A, addressing all the risk factors for cardiovascular disease. So this part is predetermined by the genes. What else can I do to reduce my risk? If I'm overweight, I need to start exercising. If my blood pressure is high, is it well controlled? I need to reduce the salt in my diet. If my cholesterol is high, am I on a cholesterol medication? So, what else can I do about those modifiable risk factors that I can control? And then, when medication does become available, you talk to your clinician whether you'll be a candidate. One of the things that we do advocate is lowering that bad cholesterol, the LDL, as low as can be tolerated with medications until there is something available targeting specifically LP little a, lipoprotein A.
Thank you. And we actually, similar, not to lipoprotein, but we just got a question. I got it through email, not through the chat. But we do have a question about, let me just make sure I get the right pronunciation of, can we talk a little bit about hypertrophic cardiomyopathy? What is it and who is at risk?
Yeah, yeah. So that is a different form of cardiovascular disease, and there's genetic predisposition to that as well, where the heart muscle becomes thickened, abnormally thickened, more so than you would see in somebody where it occurs due to just hypertension. And it can occur at any age because it is genetically predetermined. And there is an association with, if undiagnosed and untreated for periods of time, can cause congestive heart failure. So the heart muscle becomes thick over time when it can't function, it can't pump as hard, and now the heart muscle becomes weaker and bigger. Is also associated with these arrhythmias, right, and risk of sudden cardiac death. And so a cardiologist is a good individual to meet with if there is a family history of hypertrophic cardiomyopathy, so that the unaffected individuals in the family can be screened and undergo appropriate testing. That includes EKGs and echocardiograms, ultrasounds of the heart, to look at the actual heart muscle, measure the wall thickness, look at the way it pumps. And then there's genetic testing as well. So if you haven't had the changes in the heart just yet, maybe if you are positive, you have genetic testing that does show that you have hypertrophic cardiomyopathy, it requires much closer monitoring by your cardiologist so that you can catch any changes within the heart before symptoms develop.
Thank you very much. I really appreciate that. And so I'm gonna, this is not my last, but one of my last questions about an actual condition. But I think this is important. This was the point of this webinar. This webinar was really to dig deep into the different conditions that are associated with cardiovascular disease. So I'm excited. I'm happy that we have a physician on to help us talk through this. So when we talk about stroke, I'm so happy that you mentioned stroke as a CVD risk, and not everybody always thinks of stroke when they think about CVD risk. And so I want us to talk about what leads to strokes. How do we know kind of people are could be susceptible at risk for a stroke? What exactly is a stroke? Because it's well, I'll let you explain because you're the physician, right? Go ahead.
No, this is great. So there are two different types of stroke. There's the hemorrhagic stroke, and then there's an ischemic stroke. So the hemorrhagic stroke is the easier one. It's usually one mechanism, which is just basically there's a rupture of a blood vessel and you bleed into the brain. So if you ever heard anyone say they had a bleed in their brain, they had a hemorrhagic stroke. Okay. An ischemic stroke is a different mechanism, and it's usually due to one of two things. Either there's a blockage in the artery that causes due to plaque formation, so there's reduced blood flow going there, or there is a clot from the heart that caused a blockage within the artery that caused reduced blood flow. So that's an ischemic stroke. Regardless of the type of stroke you have, as you mentioned, it's really important to understand the symptoms for stroke. And I think the American Heart Association does an incredible job of educating the public about the mnemonic FAST, right? And so you're looking for any facial abnormality, so maybe a droopy face or something like that. Then you're also looking for any weakness in the arms. So maybe there is some difficulty raising the arm or the leg, so weakness, you're not able to hold on to something. Maybe they're holding something and they drop it suddenly. Speech is the other one. Suddenly your speech is garbled. You're talking to somebody on the phone and you're no longer clear. You can hear yourself and you don't understand what you're saying. And then T is for time. Time is of the essence. Just like the heart, we know that brain is muscle, and it's critical that the minute you notice any symptoms, whether it's related to a heart attack or a stroke, that you call EMS and get to the hospital. I just want to insert here that I never advocate for my patients to drive themselves to the hospital when they're having events. And sometimes some people do that Whether they think they can get there quicker, or it's a concern about cost, or they feel unsure about what's going on, and I'll just get myself there. You have to remember that EMS can actually initiate therapy in the field. So they can come to your house or your office, wherever you're having this event, and they can start treatment there. They can be on the phone communicating to the emergency room, route you to the right hospital. So if you ever are concerned that you're having symptoms of a heart attack or a stroke, call 911 immediately, and let them transport you to the emergency room and get you the care that you need.
I just want to reiterate that. I think that's so important that EMS are not just transport services, they are trained professionals that can intervene in those critical moments of a heart attack or a stroke where you need intervention to happen, right? And so, hence why, I mean, going back to the conversation we had about cardiac arrest with Damar Hamlin on the field, immediately medical professionals came out and started
Yes.
instituting CPR. It's because they had the ability to do that. And so I think it's important for us to, and we know, we want to talk about our healthcare system. Ambulances are expensive, but there's a reason why they exist. And so when we're talking about kind of heart attacks, strokes, it's really important in time. I want everybody to remember, and when we send out a fact sheet, we try to send out a little bit of a fact sheet information after the webinar. We'll make sure we put, but FAC, the fact, like the face, right?
Mhm.
What's it, speech? The face.
Yeah, so it's the face, as well as any arm or leg weakness, the speech, and then T for time.
Okay, fast, right? So
Mhm.
make sure that people remember that because that's critical. And I remember years ago when I used to work at a hospital system here in New York City. We had a hip hop artist. It was actually Dougie Fresh who had connected with a cardiologist, and they had done a comic book for kids because what they noticed is that a lot of times young kids were with grandparents when it
Oh,
was happening. And so they were
yeah.
trying to teach kids what the sign was. And it was a similar, they had a jingle or something to help them. If you see grandma or grandpa face drooping, they can't speak, call your parents or call 911, but call somebody and support. And they found that it actually really did help because you had a lot of young people who were with their parents after their grandparents after school, and they were preventing strokes. And so remember, you're never too early to learn also, right?
Yes,
Kids are a
yes,
wonderful resource and are smart and soak in information really well and are very observant, right? Kids are super observant,
yes.
and so they're a wonderful kind of audience for this message because they're so observant and they spend so much time with adults.
That's actually a great point, because we talked about sort of the symptoms of stroke, but the symptoms of a heart attack, you alluded to this a little bit, that's in women, it may be different. Now, we know that the symptoms of a heart attack in men and women, the most common symptom is chest pain. The caveat I like to give is that when I use the word pain, that doesn't mean there has to be pain, because sometimes my patients will say chest discomfort, chest heaviness, chest pressure. So any of that actually is a symptom of a heart attack. There are other symptoms that occur, some non-cardiac symptoms, and some of those symptoms may be a little bit more common in women than in men. So although it's not that women and men present differently, chest pain is still the most common one, but women are more likely to have some of those non-cardiac symptoms. And that can include jaw pain, shortness of breath, fatigue, arm or scapular pain, so the upper back kind of pain as well. Nausea is another one, or just breaking out in a sweat. I had a patient who, very active woman, although she was older, she was in her 70s, still very active, lived independently, and she started noticing that just making her bed would make her tired, fatigued. She never had any chest discomfort. But based on what she was telling me and me knowing that I was different from her norm, we decided to proceed with stress testing. And in fact, she did have a blocked artery and required a stent. So it's important to recognize those symptoms, recognize the symptoms that are non cardiac, because if you present with that, you want to immediately seek care.
And before we move on to some preventative stuff, and we have one more other question in the chat I want to ask you because I just think it's really important. We've mentioned a stent several times, right? I want to talk about what are the remedies, particularly the surgical, like when people have to have, heart surgery. And I know it's improved from years ago. I had an uncle 30 years ago who he has that scar because he had to have his chest opened to, work on his heart issues. Can you talk about what a stent does? When you still need to, and if, I don't even know if we still need to. I'm not a physician, so you'll tell me. Open somebody completely up for open heart surgery, and why? And what does that do? And what are some of the other procedures and or devices that can be used to help people? You know, people talk about having what is it, a pacemaker installed and think those kind of things. Can we talk a little bit about those things?
Yeah, yeah. So there are a number, that's the beauty of medicine is that we have had significant advancements in not just medication, but also some of our therapies. And so that's why people are living longer. They're not dying at younger ages from heart attacks compared to the way they were before, at least the number of individuals, and that people are surviving heart attacks, right? And they have many years on the other side after having had a heart attack with good therapy and good treatment. So firstly, the foundation is, of course, for treating for any blocked arteries is lifestyle modification, which is making sure your diet is healthy, you're exercising, if you're obese, you're losing weight, etc. Then there are medications that address your cholesterol for management of your blood pressure. And if you've had plaque that has progressed where it ruptured and caused a heart attack, or you were having um, angina, which is chest pain because you had plaque that developed to the point where it was limiting blood flow, there are medications for that, such as aspirin or some of the statins and a number of other cholesterol lowering medications. In the setting of an acute heart attack, when we find a blockage there, one of the things that we do is we can open up that artery. And so a catheter is inserted into the artery, a balloon is inflated that sort of pushes some of that plaque out of the way, and then a stent, these days are all coated with medication, is placed to keep the artery open, and then the medication remains in place to prevent more of the plaque formation or from the stent from closing. There are some situations where either where the blockage is or the number of blockages or other risk factors that the individual has, where a bypass surgery, so open heart surgery where you go around the blockage, that is beneficial, more beneficial than putting in stents or multiple stents. So that's where that comes into play. Open heart surgery can also be done for valves. If your valve is leaking significantly where it's causing symptoms, or if it doesn't open well, valve surgery can be done where that is replaced, and that can be done through open heart surgery. There's also newer treatments where instead of doing open heart surgery in those individuals who, for other clinical reasons, or if they're higher risk, or for patient preference, that you can actually insert a catheter through the groin, the artery in the groin, and goes up to the heart, and you can put a valve in that way as well. Pacemakers are a little bit different. Those are for people whose heart rate is too low, and so it sort of takes over the heart rate so that it doesn't fall below a certain level. That's what a pacemaker is. A defibrillator is to prevent, or if somebody has one of these abnormal rhythms, instead of having external defibrillation, external shock, you have a device in there that sort of monitors a rhythm. And if it sees an abnormal rhythm, it can shock you internally and restore a normal rhythm. So that's what a defibrillator is.
Fantastic. And this kind of benign, but we always talk about this. Are you hear maybe on television? I think people who say they have a heart murmur. What's a
Uh,
heart murmur? And
yeah, yeah, yeah. I
yeah,
love that one when I hear my patients say, a heart murmur is simply the sound of blood as it goes across the valves and through the tubes. That's the best way to explain it. There's a number of reasons why you can have a heart murmur. It could be because blood flow is leaking across the valve. It could be because the valve doesn't open well, so there's this resistance of flow as the blood is going out the valve, and so you hear that sound, the resistance and the abnormal flow. It also can be the blood is moving very quickly and the heart's pumping really hard. So if you have anemia, we can actually hear the blood flowing quite quickly. If you're dehydrated, if the heart's pumping really hard, we can hear the forceful flow of blood through the vessels. So that's what it really is. We can assess the cause of a heart murmur by listening with our stethoscope, depending on where it is. We can kind of get a sense of what the cause may be. And then we have additional imaging studies like that ultrasound I mentioned, the echocardiogram, which actually looks at the heart, looks at the valves, and confirms what we've heard about whether there's a leaky valve or it's not opening or if it's just beating really vigorously.
Fantastic. And you always hear people say, "Oh, I've been diagnosed with a heart murmur since I was a kid," and I always wondered what that means. So
Yeah.
one of the questions in the chat I want to ask, and I hope I pronounced this right, is costochondritis considered a heart problem or a rib cage pain?
Yeah, that's a good question. It's a little bit of both. So costochondritis is really inflammation, where the person will present with they're having chest pain, but it's reproducible. So if I push on the chest, it will hurt, or if the person coughs, anything that causes some motion within the chest wall, it'll hurt. It's not necessarily related to the heart itself. It's the tissue, the muscles above that are inflamed for whatever reason. This can happen after a viral infection that have caused that inflammation, and that's costochondritis.
Great. Okay, so those are the end of the kind of like what is this condition? But what I want to talk about is a little bit of prevention, even though we've talked about it in the past. And
Yeah.
I think it's really important a comment you made earlier that I want us to talk a little bit more about, and it goes with the idea of exercise
Okay.
and obesity. We know obesity is a risk factor for cardiovascular disease. It's a risk factor for most things. But it's I won't say it's not obesity by itself. It's really the inactivity that can cause obesity because you know to talk about it, you can have somebody who's obese but active and may have
Yes.
less risk factors because they are working, they're actually active and not sedentary. So I want us to talk about this idea because I love the what you said earlier about it's not just about being obese, it's about being active, right? It's about moving your heart. You can have people who are not obese who have heart disease because they're not active, and sitting is the new, and those of us who works in offices, we sit
Yes.
8 to 10 hours a day, right? And so I think that's a really important point that I think we need to hone in more on because we
Yeah.
we we tend to demonize obesity, and it's an issue. I don't want to say
Yes.
it's not, but it really is the inactivity part that is really what's impacting our heart. So I want you to talk about why being active is so important for our heart and what inactivity does to everybody when it comes to heart disease.
Yeah. One of the things that is recommended by the American Heart Association, they provide some guidance on exercise. And the recommendation is for 150 minutes of moderate intensity exercise weekly or 75 minutes of vigorous intensity exercise. And so swimming and playing basketball is considered vigorous, whereas maybe walking, line dancing, yoga, not yoga, but line dancing, that may be considered more moderate intensity. The other part of that that I think is often neglected, especially amongst women, is strength training. That's also part of the AHA recommendation for physical activity. And that is that we participate in some form of strength training exercise twice, at least twice a week for 10 to 15 minutes. One of the things that I see often is that we don't talk about the benefits of exercise, right? It's not just, as you said, we're not doing it to lose weight. That's great. To be honest with you, most of the weight loss comes from dietary modification, and exercise is more for maintenance. But when it comes to just really overall good cardiovascular health, exercise, remember the heart and the lungs are muscles. And so exercising those are actually good for you. It's also the foundation for treating high blood pressure, diabetes, high cholesterol. I've had several patients over the years that I've been treating my patients that if you, with changes in lifestyle and exercising, they've been able to lose weight and their cholesterol has improved or their blood pressure has improved to the extent that we've actually had to decrease the dose of their blood pressure medications I've seen. I think the other thing that we must take into account is what are some of those barriers to exercise? So some of it is motivation, right? Some of us, we may not like exercising, right? And so the first thing I'll say is, what kind of activity would you like to do? Just because everybody is going to the gym or everybody's out jogging doesn't mean that that's what's right for you. If you love to swim, especially if you have joint pain, maybe my RA or lupus patients, I recommend that they go into the pool because that's at least weight bear, non-weight bearing, and it also helps to build muscle the resistance from the water, and they're exercising without causing further injury. But one of some of the barriers include cost. And so for those who feel like they need to be in a gym, I don't subscribe to that theory. I think that one of the things that came out of the pandemic is we learned to do a lot of things remotely, and there is a wealth of resources on YouTube or online, a lot of online resources where there are free exercises, or if you wanted to participate in a class, so you can do that remotely. I think the other thing as far as barriers that exist are that some people are the head of their household, and it may even be a single member, single parent household. And so childcare can be a difficult issue to resolve. And even if you're in the home, if you have a really young child, it's hard to take your eyes off them for 5 minutes, forget to do a 30-minute exercise. Um, and I think the lastly, then, even if we don't go to the gym or we don't have childcare issues, ensuring that you have a safe place to exercise. So there are some neighborhoods when we talk about social determinants of health where you may live in a neighborhood that doesn't have any sidewalks, maybe doesn't have a safe park for you to go to. And so that may be a barrier. And so I think understanding some of those challenges helps us provide recommendations for patients, but we do need to continue to encourage everyone to participate in exercise. It improves your blood pressure, it improves your cholesterol, like I said. It actually is also beneficial for mental wellness, right? When my patients are feeling anxious or depressed, I encourage them to get out there into the sunlight, exercise. You have a communal activity if you're part of an exercise group. It actually helps sleep as well, which is another important factor. We're not getting enough sleep in this country, and we know that's tied to cardiovascular disease. So there are many benefits to exercise, and I think we need to encourage everyone who can to participate in exercise. And if you have some limitations, trying to understand what those are and how do we provide accommodations to work around those.
No, I love that you just said that that encourage everyone to exercise because there's more benefits than just losing weight.
Yes,
There's benefits to your mind, to your mental health. There's benefits, of course, to your heart. And I
yes,
think the strength training one, when we think strength training, I think a lot of people, me too, think the muscle man in the gym like Arnold Schwarzenegger back in the days. But it could be light, it could be low impact like the pool, it could be things like Pilates and yoga, which are strength that uses your inner resistance and your core to do strength training. And so we also have to expand what exercise is. It could be line dancing, right? It could be pickleball. I mean, we had a pickleball craze during pandemic. I don't play pickleball, but I just think it's funny. But it also is, encouraging folks to do what you like. If you enjoyed playing basketball as a kid, joining
yes,
a league for older, I have a friend who played basketball when he was younger and now as a, middle-aged man that he's part of a league and he's like, we're at the same speed so we can, they still talk trash, they still do all the things, but he's not playing against young guys who are
yes,
dunking on him. He's playing against guys who are his own age. And so, and I also think other thing too, I love what you said about head of households who may not have the time, but maybe finding a way to include kids. I mean,
yes,
young kids is hard because they have no attention span. But as they get older, including kids in exercise routines at home, because then it also gives them the lesson that this is something I should be doing, right? My mom did yoga, or my mom did this step class or this Zumba class on TV, and I had fun and we did it together. And now I know that this is something that's part of the routine. So I think this is really important. I think sometimes we harp too much on we got to lose weight, we got to lose weight, you got to
yes,
lose weight, and not like even if you're not losing weight, this is good for your heart, right? Yes, we want to reduce weight if you're obese, but if you exercise is good no matter what. Exercise is also
exactly.
good at any weight, at any age, at any stage, because it's good for your heart, it's good for your mind, and it's good for your well-being. So I appreciate you saying that because I think that's message sometimes get lost in all of the sauce of, our kind of see me culture, right?
No, I think you're 100% right, and you're talking about building healthy habits for our kids, right? Is if they start exercising and this is part of their normal life, they'll do this through different stages of their life, right? And I think the other thing is we see an explosion in childhood obesity, childhood type 2 diabetes. And this is because of not just unhealthy eating, but obesity and lack of exercise. So I like the way you said that exercise is good for any age, at any weight, at any time. So you should coin that. That was actually great.
Somebody's gonna already take it, but I'll take it. I'll take it. And we have one last question because we're running out of time. This is a little bit specific, but I think it's important. And I want to say with this question, I'm going to ask it, but I think it goes back to what we're saying about making sure you write down and ask your
Yeah.
doctors the question. So the question is, my doctor mentioned that there's a research suggestion that with diabetics over 60, you should be on a statin, even with a good cholesterol level. Is this something I should be concerned about? Thank you.
Yeah. I wouldn't say you should be concerned about it, but the American College of Cardiology, American Heart Association, we have guidelines for the treatment of high cholesterol, and there's a separate guideline for prevention. And that is true. We know that diabetics are at increased risk for cardiovascular disease. And even among women who have diabetes, there's a 60% greater chance of developing a heart attack compared to men. So that's what's unique about diabetes. And so the recommendations are that depending on your age and your cholesterol level, that diabetics do take a cholesterol pill because we know that will reduce your risk of a cardiac event. So even those 40 to 75, I forget what age this individual said they were.
60.
Yeah, yeah. So right within that age. And there's certain cholesterol, LDL, specifically what we follow, LDL parameters, your doctor may recommend a cholesterol pill, a statin, which is our first line treatment for lowering the LDL cholesterol. That would be correct because that would be to reduce one's risk for cardiovascular disease.
Okay. Well, we're essentially at time. So I do want to ask Dr. Isiadinso, what is kind of your last parting final words for our audience and for the folks who are going to see this on YouTube later? And then I'll close us out.
Yeah, I think what I'd like to first is just thank you for this opportunity just to speak to your audience. You know, this is a Heart Month, but every month should be Heart Month. We know that given that it's the number one killer amongst both men and women, it's something that we need to be well educated about. We talked about some of the risk factors. I want that to be a take home point for everyone, both some of the traditional risk factors and some of the female specific risk factors, the importance of your pregnancy history when it comes to understanding your risk and communicating that with your clinicians. I think we really drove home the point of physical inactivity and the importance of exercise. It's never too early to consider seeing a clinician to talk about preventing heart disease, right? So whether you're someone who has a family history, if you don't have a family history, you're worried about your risk factors, or you're healthy and you want to remain healthy, all of those are the right individuals to speak to a clinician to better understand their risk and to be educated on what can be done moving forward to lower your risk or to remain at low risk if you're already there.
Fantastic. I mean, I think you've summed it up best. This is Heart Month. Heart disease, we know, cardiovascular disease, and it's, ascendant risk factors are the leading cause of death of everybody in the United States, but particularly of Black people. And so it's important that we understand our risk. It's important that we talk to our families about our risk and understand what the familial risk is. It's important that we talk to our doctors, as the question was asked about what can we do to reduce our risk. It's important to make sure that we eat healthy, but also exercise. And just take care of our hearts because our hearts are what's pumping blood throughout our bodies, and they're an important organ. And so during this Heart Health Month, I just want to thank you so much for joining us and for giving us all your wisdom and taking the time out of your busy schedule and in having time to bring this information to the National Urban League movement. So thank you so much, everybody. Have a wonderful day. Happy Black History Month. This is also Black History Month, and so this is important for our people. And thank you so much. Have a wonderful day. Bye, everybody.